Hello everyone, it's Connor. Today we're going to talk about the POLST, the Provider Order for Life-Sustaining Treatment. There tends to be some confusion around how to properly fill this out, and I don't blame you. It's a confusing document. It's not straightforward. You should never just give a POLST to the resident and tell them to fill it out. It should always be explained. Sheila Johnson is the individual that helps us out with POLST-related questions. I've asked her many questions in the past. I've taken a POLST class with her, so I'm going to just walk you through some of this in a little bit more detail. So up here is the POLST, Provider Order for Life-Sustaining Treatment. When you walk into a room, the resident many times will say, hey, where's my advance directive? I have an advance directive. I don't need a POLST. The advance directive is that document that states what their wishes are. That tends to be filled out about 20 years earlier. And it just, things change with a person. Things change when they go to the hospital, when you receive new diagnosis. We want to do a POLST because that is an updated provider order that tells us what to do in the event of an emergency. We want to do these upon admission when someone comes out of the ICU. Perhaps their goals changed. Maybe they got a poor prognosis. Maybe they have a better prognosis. Either way, we want to look at this upon admission and then quarterly at our care conference or any time there is a significant change with the resident. So again, looking at the POLST, we always want to put the name on top. Fill this out completely. Don't leave anything blank, all right? I cannot tell you how important it is to get the signature at the bottom. Now, this is still valid without a signature from the resident or the family, but when we get this signature, we ideally want to get the resident's signature. Even if the resident is not cognitively there 100%, their wishes should always be looked at no matter what state they're in, and the signature at the bottom carries a significant amount of weight when you do get to the emergency room or the hospital, even more so than if you have just a family member signing. Anyway, starting at the top, the section A is a section in of itself where there's just two choices, CPR or DNR. Attempting resuscitation means that you are going to allow the staff to do whatever it takes, whatever is humanly possible to save your life in the event that your heart stops beating or you're not breathing, okay? So in order to be CPR, you have to be full treatment. You have to have a patent airway to run a code. Sometimes that involves putting a tube down the throat and manually pushing air into it. Also, when a person codes, we don't exactly always know why. That airway has to be examined first. So, and keep in mind that when you are full treatment, as with any of these, all patients do receive comfort-focused treatments, okay? So, attempt resuscitation has to go into the full treatment category. Now, many residents will say, try resuscitation, but I don't want to be on a machine the rest of my life. I don't want to be on a ventilator. The decision to remove the ventilator, to remove the intubation, can be made at any time. On the back of the form, you can say, hey, I want to do a trial period with a ventilator. Give me a week, give me a month, or just I'm leaving it up to my family. But initially, to run that code, we need access to everything. The hands of the physician team cannot be limited in the event of a code. The next part we'll get into then is do not attempt resuscitation, or as I like to say to residents, do you want us to let you pass peacefully? When there are residents with multiple comorbidities with a poor prognosis and they still want to be full code, it is sometimes beneficial to just go into the stats of this, okay? So if someone codes, 1 in 20 are going to pass away. 1 in 20 will survive, 19 in 20 will pass away. As you can imagine, in our setting, that's going to be an even worse statistic. Going through the code itself is not pleasant. The emergency room will bring over the Lucas, that machine that goes onto your chest, and it will compress very deep, okay? You will have blood spewing out of your mouth. You will have your ribs cracked in all places. If you do happen to come back, you're going to be miserable, and the chances of you coding again when you come back are substantially higher. And even if you do come back, let's consider the cognitive impairment that can happen. Brain damage happens only 4 minutes after an individual's heart stops beating. The brain needs a lot of oxygen, and if it doesn't get that oxygen, it's going to be damaged just like any other organ. So if you are choosing do not attempt resuscitation, you have two options: selective treatment or comfort focus. Most of the individuals we care for do choose to not attempt resuscitation, but then go with selective treatment. So if something comes up, they still can go to the intensive care unit. Try to avoid it if possible, but the selective treatment still leaves open the option of doing whatever we need to do to keep you alive and bring you back just up until that point of death. Intubation, mechanical ventilation, those extremely invasive procedures will remain off the table, unless, of course, you or your family change your mind. And then there's the comfort-focused treatment. If you do not attempt resuscitation, you can be comfort-focused treatment. That is fine. We see this with a lot of hospice residents, along with individuals that just don't have a very good prognosis. To keep you comfortable means that if something goes wrong, we absolutely can run diagnostic tests here in our setting. We can get labs. We can get chest x-rays, CTs, you name it. But we're going to avoid the emergency room. We're going to avoid the hospital. If it comes down to it, we can treat you with antibiotics in our setting. Again, avoid the hospital. And if the end is near, we just work to keep you comfortable. And we definitely have the means to do that. We don't need the hospital to do that. So, one other thing to mention, you can be DNR and you can be full treatment. This just means that you want the team to do everything medically necessary to keep you alive until the point of death. If you no longer have a pulse or you're not breathing, they just stop, but do everything up until that point. So, just a quick recap. If you're CPR full code, you have to be full treatment. If you're DNR, you can choose to be any of the 3. You can't be all 3, I'm sorry. You have to be one of the 3, okay? But typically that DNR is going to fall into the selective treatment measure because that is going to maximize the comfort, but at the same time, work to keep you alive in a pretty faithful manner. At the bottom, if at all possible, we want the patient to make these decisions and we want the patient to sign. A lot of times when residents see these forms, they get scared. They want to wait until they can go home and find their advance directive or talk to their family. If the resident comes from the hospital and there is no order, no code status, which is going to be rare, but let's say there is none, and they refuse to fill one out and sign, they are going to automatically default to a full code until we can get that information. We always have to err on the side of caution if we don't know a code status. So if they are adamant about being do not resuscitate, do not intubate, we need that information right away and we need them to sign. Finally, at the bottom, section D, this is an order, which means a physician, nurse practitioner, or physician assistant has to give us the blessing, the okay. This can be a TO. If you know there's a provider on call, you can TO their name in. Make sure you actually call them though. If their prognosis just doesn't quite jive with the usual goals of care, it is something that should be talked through. But 9 times out of 10, whatever the resident wants, we will honor that initially. On the back, section E, you got other options. Doesn't matter if you're full code or DNR, You can choose all or you can choose none. So think about that artificial nutrition by tube. Do you want it long-term or short-term or not at all? And the same thing with antibiotics. And finally, we would love to know who signed the document, because if a question came up and the resident can't answer, maybe we can go give you a call and say, hey, do you remember what so-and-so said that day? Maybe it'll jog your memory. One issue that has happened in the past is that a resident I can think of chose DNR, they chose DNR, but they chose intubation. And that is okay as well. If someone their throat's closing up, let's say they're having an allergic reaction, if intubation is okay, we want to know that. If they code, we aren't going to do anything about it, but do we have permission to keep that airway open if you're DNR? That is also good to know. On the back, please make sure family is aware that the decisions that they make today don't necessarily have to stand for the rest of the time here. A POLST can be changed at any time. It can be changed if the resident just says, hey, I want to change it, and we have to honor that, even without a signature. That's really the basics of this. We do want to get this into the plan of care and the orders right away. Nothing would be worse than going into point-click care after a patient codes and finding that there's absolutely no orders. And then we go into the chart and we can't find the orders because it's sitting in the folder waiting to be signed. We always want to have it in point-click care ready to go. If you have any questions, just give me a shout out. Thank you.